our model right now at the Barbara Davis Center, and this is the norm, is the provider, the diabetes provider sees the patient, then maybe social work will see the patient, and then if there's something significant going on psychologically, I'll see the patient, but it's sort of back-to-back mini appointments within the main appointment. But what would be really amazing is if we were all in the room together, working together to address these issues. Then it would be the medical team, really, yeah. And you don't have to do a super long interview to get at the basics. It could be simple questions like, are there any significant stressors going on in your life? Is anything bad happening? Is anything good happening? Just to connect with the patient on that level. I think ultimately it will start with at the very basic level, the quality of the relationship between the provider and the patient, and just having frank conversations with them about what works for them and what doesn't work, and then trying to problem solve with them on how to make improvements at a small level. If a patient is only testing, let's say, one blood glucose monitoring one time a day, it's not feasible to expect them to all of a sudden start monitoring 4 to 6 times a day. So just having a brief conversation like, what can we do to just increase that by 1 reading a day? It's little things like that. That's the hard part. And so as a patient-oriented clinical researcher, we do so much of our interventions in a research setting, even though it's also in a clinical setting, and then disseminating it into the real world is a challenge. I think that what we have to do as behavioral scientists and clinicians, like psychologists, is to advocate for ourselves and educate the institution, the departments, the physicians about what we can, a big picture, contribute, but also that the interventions that we have available work. And so if we could get the buy-in for that, for it to be standard of care, but that's a challenge.